Hello, I'm Dr. Nanette DeBrule. I'm a radiologist at UCLA in the Department of Radiological Sciences. I'm one of 7 radiologists that specialize in breast imaging. And we are at 3 locations, primarily in Westwood, the 200 building at the Iris Cancer Center for Breast Imaging, in Santa Monica at the Barbara Court UCLA Women's Imaging Center, and in Manhattan Beach at the UCLA Imaging Center. So welcome. And I want to thank everyone for allowing me to present for Breast Cancer Awareness Month and to be able to discuss something that I do every day and to try to help you understand some of the things that are important in women's health. Just wanted to let everyone know to ask questions on Twitter using hashtag UCLAMDchat. And after that, I'll put them in, put your questions in, but hopefully I'll be able to answer the questions that you have through this lecture. We're going to go through the images and we'll get started. Just going to talk about breast imaging and screening and diagnosis. I'm going to have an overview of the tools that I use: mammography, breast ultrasound, MRI, which is magnetic resonance imaging, tomosynthesis, which is the new 3D mammography, and talk about some of the breast interventional procedures that we do with the image-guided biopsies. I want to first discuss the use of screening versus diagnostic examinations. A screening procedure is an exam for asymptomatic women. Those are the women who do not have any complaints, and they're coming in primarily for screening, and that we are looking for a lesion that it could not otherwise be detected. Screening mammography is usually performed initially in age-appropriate women. Diagnostic procedures are those procedures and examinations that are performed for those women who have a specific complaint. That means focal breast pain, a lump, breast thickening, changes in the nipple discharge that's usually bloody or clear and usually just from one opening, or special cases such as recent diagnosis of breast cancer or for follow-up of breast conservation. These include the other tools, including mammography, breast ultrasound, and MRI. So I just want to talk to you about from whence we've come, the evolution of mammography. On my far screen, you see that in 1940, they actually what we call the industrial mammograms. And then through the years, we have improved our technique of imaging the breast. It's amazing that the doctors were able to identify the lesions that they found even in those eras. And as we progress through 1988, that is the film screen mammography, and that's often similar to where photographs are obtained. And then lately, and we improved our imaging to the digital world in 2006, where the images are actually placed into an acquisition system and is able to go to a workstation, and we actually are in the image our breast with digital, and we can improve our imaging. And we are continuing to improve as time goes on. So I know everyone asked this question, so I wanted to get it out early. This information was obtained from the radiologyinfo.org, radiation safety site with the American College of Radiology. And so I want to put dose in perspective, and many people talk about it and based in terms of the background dosage that we have from natural background radiation. So in 1 year's time, our dose from natural background radiation is about, the term that they use is called a millisievert. Now just to give you an idea what that means, and I'm not sure how this slide is projecting, but the radiation safety, what they call the risk levels. Once you have been exposed, it's negligible, means that it's 2 days of the natural background exposure. Minimal risk is more than 2 days, up to a month, and very low risk. And as you can read on, that it advances to moderate risk, which is more than 6 years of natural background exposure. Now to give you an idea of what some of the radiation doses that we use in imaging, if you have a dental exam, it's equal to about 1 day of natural background radiation, and then that's considered negligible. A chest x-ray is equal to about 10 days of natural background radiation, and that's considered minimal. Mammography is considered about 7 weeks worth of background radiation and very low. When we go further into the other more specialized examinations that are not used, is primarily used for diagnostic examinations, the computer tomography, which is, this example here is abdomen and pelvis without contrast, which is equal to about 3 years worth of background, natural background. And it advances if we have to do with and without contrast, then that doubles. But I have to understand that medical radiation is only a small percentage of the amount of radiation that we receive every day. The screening guidelines I want to talk about are through the screening guidelines for breast imaging. The American Cancer Society, the American College of Radiology, and the American College of OBGYNs recommend annual screening mammography beginning at age 40. Previous recommendations were at 35. Now, with special circumstances, screening still can begin earlier than 40. Women who've had radiation exposure, example is Hodgkin's lymphoma, they expose the chest. Now, other radiation exposures can cause it, but now we've gotten better with our radiation. The doctors in radiation oncology are able to block and evaluate and give the dosages in a smaller place, so the risks are getting smaller as we continue on. If there's a mother or sister with premenopausal breast cancer, those also may begin earlier depending upon when they actually develop cancer. And those women who are gene positive, they call them the BRCA1 or 2 gene, those are the ones who are at a higher risk of developing breast cancer, as well as ovarian cancer. Just to explain mammographic positioning, these are 2 views of a woman who is actually getting a mammogram. And yes, even with the digital mammography, we still need compression. And they tell us to stop holding our breath, but I don't know why, because the moment I go in to have a mammogram, I stop breathing. But I just want you to know that we take 2 views because you want to be able to evaluate the breast in all aspects, from the top to bottom as well as from the side to side. So what we see as an MLO, that's the top to bottom view, and the craniocaudal is that we can see from side to side and be able to identify if something shows up and is real. Now, I'll give you an example. This is a normal mammogram. We see it's a very well-positioned mammogram. It has the pectoralis major muscle. It's right through here. And the nipple, the outline. We look at both views. This is the medial lateral oblique, so all we can tell is from the head to toe. Here is just a benign calcium deposit, and I'll show you other things. We see those very often. This breast tissue would be what we would consider moderately dense, not that dense at all, because the gray is what we see is considered the fatty areas of the breast. And the one thing that's great about fat is good in the breast. We love fat because it helps us be able to see breast tissue, the surrounding tissue, and if there is a cancer, it will give us a background to see it better. This is the craniocaudal view, and again, this line is the pectoralis muscle, this is the nipple, this is the inner breast, that's the outer breast. And that's how we evaluate things in those views. Now, to give you an idea of what I see every day, these things look pretty scary in here, but these are benign calcium deposits. I showed you that one calcium deposit, but these are benign calcium deposits. On the far screen is a woman who had silicone injections, so those very white, bright areas are considered silicone, residual silicone. On the next screen is calcifications of a woman who had trauma, and she developed these calcium deposits, these round circles that you see here. And the next screen is a woman who has normal secretory calcifications, just they solidified, just the secretions. The breast is a gland, and it secretes, and we just have normal secretions through here. And this one, again, is just a single calcification. It's a coarse calcification of most likely a benign mass that has calcified through time. Often we see these, they call it popcorn calcification, known as a degenerating fibroadenoma. On your far screen, though, these are abnormal findings that I see. When I see calcifications that are grouped, that are following the ductal pattern, that are irregular, that are different shapes and have lines, those are the kinds of calcifications that are associated with oftentimes precancer as well as invasive cancer. Precancer is also known as ductal carcinoma in situ, and is often not physically able to feel it, or what we call not palpable. On the other screen here is a suspicious mass who, in this particular patient, was something that she could feel. And it's very irregular. The margins are what we call cancer the crab type of finding. And this is what we see. And we have a higher suspicion that this may be malignant. So just to let you know, though, most findings that we see on mammograms are benign and not cancerous. So mammography sensitivity, I think it's very good. We do know that it has decreased the mortality anywhere from 30 to 50%. And because it catches things very early, oftentimes catches it early, that it is primarily localized to the breast and has not spread. Those are the ones that we try to catch, the very early small cancers. Many factors affect the likelihood of detecting breast cancer: positioning, compression, sharpness, and those are all the exposure and effects from the technologist making sure that all of the breast is imaged. So that's why she has to really pull you in so that to make sure that all of the breast is imaged. The other thing is that the density of the breast, and we'll talk about that later, is very important and most important in detecting, because if the more fatty breast, the better we can see. The denser the breast, it's harder to see cancers because they blend in with the tissue. So every woman has a different admixture of the fat to tissue ratio. And to let you know, it's almost like fingerprints. We can almost, every woman's breast looks different. Okay, and it can vary with age, your heredity, and of course the hormonal status. So premenopausal women tend to have denser breasts, and postmenopausal women tend to have fattier breasts. And again, fat is good. This is an example, and we're going from the highest sensitivity to the lowest sensitivity of mammography. This is a completely fatty breast, and you can see that it's very gray. The next screen is where we have islands of small amounts of breast tissue. This screen, it's beginning to appear whiter. This breast tissue is what we call heterogeneously dense, and this is extremely dense. So you have the fatty breast, you have the scattered fibroglandular tissue, you have the heterogeneously dense, and you have the extremely dense. Now this is an example of what a tumor would look like. That white dot right here, irregular mass. In that breast, you can clearly see it stands out. We can see it very easily. In the next one, it becomes less conspicuous. And as we progress through the density of the breast, it's almost disappears completely in the extremely dense breast. In 2013, or April, there was a California law that required patients to be informed of their breast density. And we have a certain statement that on all our mammograms, you will see at the bottom of your report that's letting you know whether if you are a person who has dense breasts. So only approximately 47 to 50% of women have the heterogeneously dense breast, and this is probably somewhere about 40%, and this is somewhere about 10%. But combined, 50% of women have what we would call dense breast tissue. The other mammograms that we see, and primarily the women that we see, have this type, where it's much easier to see the breast cancers. So we wanted to let you know that for all these women, this letter will indicate, and from that, the law requires that you can talk with your doctor to see if there's any additional imaging that needs to be done. And as I mentioned, only 10% of all the women who have extremely dense breasts, that was that last image, and it's associated with just a relative risk of cancer, approximately twice, with the average breast, relative risk of 2 compared to the average dense breast, which is that one that we considered the scattered fibroglandular dense breast. 40% of women have heterogeneously dense breasts, and their relative risk is 1.2. So the breast density is not a major risk factor per se. Now, you're going to see a lot of different information on different websites, and relative risk and absolute risk and all of these different kinds of things, depending upon how they use their definitions, the actual numbers will change. So what tools do we have to improve imaging of the breast if it is dense? One of the answers is breast ultrasound. And just to give you an example, when I first started a few years back, this was what we called a water bath ultrasound. And the woman actually laid down, and this machine looks like it's something that should be going to the moon, but it actually imaged, and the quality of the images was okay. But as time has progressed, we have improved our ultrasound imaging, and we are now using primarily the handheld ultrasound units. But we also have a whole body screening type of ultrasound unit that actually can give three-dimensional imaging. And so we are moving and improving all of our imaging devices. Ultrasound uses sound waves to see through dense breast tissue. I tell everyone I compare ultrasound to sonar, which is used in the ocean, and that tissue bounces back, you see an image, and if it's water, the image goes through, and it's primarily, and the beam goes through, and it's water. There's no radiation, that's an advantage, and we commonly use it, and primarily we use it every day for diagnostic imaging. Again, for those women who come in with a palpable lump or an abnormal mammogram, and we further evaluate with additional imaging with mammography and also with ultrasound. And just to let you know, when we're doing the screening mammography, we call back about an average of 10% of the women. Again, because of the fact that we're taking a three-dimensional object and putting it into 2 dimensions. And a lot of times there's overlap of tissue. So if you do get a call back on your mammogram, most of the time it is just overlapping tissue. But we further evaluate it with additional imaging and ultrasound. So this is an example. On the far upper screen is normal tissue. You can actually see the skin surface begins at the top. And then we have the breast tissue. And here's muscle that has a different kind of look with ultrasound because it has a different kind of material and striations through it. And this is the breast cyst. This is what I talked about. When the ultrasound beam hits water, it goes straight through. And that's why it looks dark. In this case, this is a mass. It has smooth margins. It's a benign mass. It's a very common mass, which we know as a fibroadenoma, which is similar as the fibroids that many women know about in the uterus. Similar kind of process. A single cell whirls up into a ball, and it develops a lump. Feels like a little marble moving. We don't ignore these because some cancers can have a smooth border. However, most cancers look like this far lower screen, the near screen, where the margins are irregular. And this is a small cancer, and this is what we look for. We also use magnetic resonance imaging. MR imaging is based on the interactions of the hydrogen atoms in tissues, and it bounces around in there and it creates an image. And we use radio waves, and again, this is non-ionizing radiation. We look for the shape, those terms like morphology, and we look the pattern. What's very important for everyone to understand is that breast MRI requires, if you're looking for tumor evaluation, it requires contrast injection. And we use gadolinium as our contrast agent, which is different than what we use in CT. But we still try to let everyone know that there can be allergic reactions, so just let us know if you've ever had any kind of reactions to any kind of contrast. We use this imaging, the gadolinium. We take pictures before we give the gadolinium and after, and it actually will light up comparative. Unlike mammography, breast MRI is not affected by the density of the breast. Now this is an example of a woman who's had a contrast injection. We have subtracted out. We use tools to be able to increase our imaging, to be able to see through the breast. We actually subtracted out the breast tissue. And what you see here, these lines through here, are the normal blood vessels. The breast is a very vascular organ, and these are all normal. and there is no evidence of an enhancing mass that we would consider suspicious. To let you know, benign masses can enhance, postoperative changes can enhance, so it's very, very sensitive. Its specificity is a little less, but it's very important to know that it can, and we can see cancers that may not be seen on other imaging studies. There are also cancers, though, that cannot be seen by MR, by mammography, or ultrasound. That particular type of cancer can be known as lobular cancer. Most cancers are invasive cancers, invasive ductal. But there are types of histology types of cancers that will elude us. These are just computerized interpretation of your breast, and so mammography and any of the imaging studies may not find the cancer. However, with clinical breast exam, and that's why I always try to let the women know to make sure that you see your physician and have your breast exams. And if you are at a higher risk, you should have more frequent examinations. Now on the next screen, this is actually a cancer that is enhancing. So again, relative to this, to the surrounding tissue, there is a very, very irregular mass that lights up, and we can clearly see it. Over here is probably a lymph node or some other vessel that overlaps. But again, this is 176 images went to make this picture, and it's an average of about 1,000 images that we then actually reformat. So this is a reformatted image of a breast cancer. Now this is an example of another patient who had the breast MR. She has a known cancer here, and it was the precancer, the ductal carcinoma in situ. That too can take up contrast, especially when it's in large quantities. And this actually showed up as abnormal calcium deposits on the mammogram. But what we didn't know was that she had an unexpected infiltrating ductal, we call it a high-grade infiltrating ductal carcinoma, in the opposite breast. So we do look for what we call contralateral disease, which can occur in 3 to 5% of women who have a diagnosis of breast cancer. So the advantage of MR, in a nutshell, is that it's very sensitive, over 90%, but again, our specificity is a little bit less, and it varies depending upon the reports and the data that you see. It is not a substitute for mammography or conventional imaging. All of these images, mammography and MRI and ultrasound, are adjuncts to mammography, and that is very powerful, and we use it for high-risk screening for those women who are gene positive or who have been seen by the high-risk program, which we have here at UCLA. We'll evaluate your risk and be able to also evaluate those women with newly diagnosed breast cancers to look for additional cancers or to see how extensive the cancer is, and also for anyone else who may have other specific reasons for it, like say even the radiation patients with the Hodgkin's lymphoma that actually got radiated. Those would be considered high risk and actually can get MR. Now I'm just going to move to another area that people ask me a lot about, and this is about breast augmentation. These are implants. And these are two different types of implants located in two different places. This implant is a saline implant. It's fully inflated. It is in front of the muscle. And then we have, on this screen, we have a silicone implant where it is behind the muscle, and it's very dense. And you can see that it's, even though it's saline, it's still difficult to see through it on mammography. So our technologists do different techniques. They do implant displaced views. They physically push the implant back and bring the breast tissue forward. These are skilled, trained technologists who work very hard to learn these techniques to be able to maximize the imaging of the breast. Now to give you an example of what these saline implants can look different, this is an implant that has lost its water on the left side, and on the right side is that other image where I showed you. So this is a deflated implant. And you do not need any specialized imaging to see this. As you can see clearly, mammography can identify this. Now these are different examples of implants that may need additional help with other studies to actually look through it. This is again a woman who has an implant. Again, this is clear in here. So therefore, we have a low suspicion for implant rupture. This woman, it's clearly that you didn't necessarily need to have an ultrasound to determine that these white circles here are actually free silicone. Now, to just let you know, this is a very old image of what we would call free silicone, because many of the implants are now made out of materials that would not have that type of oozing effect that happened in these earlier implants in the 90s. So many of the women who are receiving implants now, after the 1990s into the 2000s, received the types of implants that do not have the type of extent of the silicone getting outside of the fibrous capsule that the body forms around it. So, but the earlier implants were more liquidy, and therefore it created, the body was walling off the silicone that escaped the actual capsule. And these are just an ultrasound showing you those nodules of how it looked like under ultrasound. Now, this is actually an MRI of an image of a woman whose implant looked perfectly normal on mammography, but in actuality, under ultrasound, she has these little white lines going through the image, and she has these curvy linear lines going through the MRI. What was also unexpected was that there was some silicone going behind the pectoralis major muscle. So this is called a ruptured implant. It is what we would call extracapsular silicone extravasation. So this is just to let you know that these are other things that we see, and you do not need, if you need further information on these breast MRI, if they're just looking for implant rupture, breast MRI, and there are no other signs mammographically or by ultrasound, breast MRI is about 97% accurate in evaluating for unsuspected implant ruptures. Now, what's the future? We're moving forward, and we now have what we call digital breast tomosynthesis. This is a 3D mammogram. How does it work? Well, the breast is compressed just like the mammogram, can't get away from that. But there's a tube that actually moves and creates images. It takes multiple images across the breast in a series of low-dose images, and then they get reformatted. The total dose is similar to what we use in digital two-dimensional mammography. They're reconstructed. They improve the visualization of fine detail, and it helps to overlap some of that overlapping structures at 3 dimension, and an ability to uncover cancers hidden by some of the denser breast tissue. So this is just an example of how it works. I'm just going to touch the screen, see if it works there. And this is just an example. This was given to us by the manufacturer. And it is now reformatting the 1 millimeter slices. It's coming in. And then the images get slowly and reformatted. And it gets into a 2-dimensional image. And here it gets enhanced. There is an irregular mass here, which is a breast cancer. So tomosynthesis, we do know that through some of the recently reported, they've had tomosynthesis in Connecticut and at other sites much longer. And so there are a lot of data that comes out of that area. Dr. Rachel Brem did a lot of work. 27% was an increase in detection of all cancers in dealing with invasive as well as in situ. We also had a 40% increase in detection of invasive breast cancers using tomosynthesis. And because of the fact that we can actually see 3-dimensional, and some of those callbacks that we had, those 10% of the callbacks, we can reduce it when we use the tomosynthesis. This is an example of a 2-dimensional mammogram. There is an abnormality there. There's a marker here. So I want you to keep your eye there. And in this image, I'm going to touch the screen. Begin to see, slowly but surely coming into view. There's a mass here. I'm going to give you the magnified view. This is the 2-dimensional view, and then this is the 3-dimensional. This is the slice that actually showed it the best. These slices go across, and then we're able to look at it in which portion of the breast. Sometimes things that are only seen in one view, we can actually determine where they are in the other view, whether it's inner or whether it's outer. Again, this is what the two-dimensional. You can kind of get a hint that there's something irregular in this breast, but when we got to the particular slice, it's clear to show that there is a very irregular spiculated mass hiding in this denser breast tissue. Again, this one looks very smooth, not overlapping tissue. This is a two-dimensional view. And here, on the particular slice, there's a very irregular mass, which is consistent with malignancy. There are other things that can present with irregular borders, but they will still require biopsy. Again, this particular case, this one is palpable, and here it is. We can clearly see much more detail of the malignant mass. Now, on my near screen, in the circle, there's something that's irregular on the image. And so we're using the 3D tomosynthesis to further evaluate that. And on this screen, as you keep looking, we keep looking as it goes through, and we don't see it. And that, I'll run it again, this area did not persist in the manner in which it was seen on the two-dimension. So that's an example of an overlapping tissue that can actually reduce the callback rate, because we wouldn't call her back because we know that that was just overlapping tissue in the two-dimension. The three-dimensional object got put into two dimensions, may have been positioning that the tissue gets bunched up in that area, but when we repeated it with the three-dimensional, it was just normal tissue overlapping. These are the devices that we use for image-guided needle biopsy. Many of these are handheld, or they can be attached to a special device. This table that I'm speaking of, that these needles can be attached, is on a stereotactic core needle biopsy machine. The woman is laying on her stomach. The breast is suspended, and we then compress the breast so that we can hold the breast as well as image the abnormality. These stereotactic core needle biopsies are done primarily for those findings that cannot be seen under ultrasound or are best seen under mammography. And what we see in this particular case, the arrow is pointing to on the far screen, of calcifications that were found on the screening mammogram. And we can see here that in this screening, once we've taken the tissue, it gets into a chamber of one of those needles that we showed you, that the specimen radiograph clearly shows that we obtained the calcifications. Now, the calcifications in themselves just represent byproduct of breast activity. The calcifications are formed by tissue surrounding it. So what's more important is what is the activity of the tissue surrounding the calcifications. Calcifications are the most common finding in a woman's breast, and just the pattern of the calcifications and how they appear is what determines whether we need to biopsy or not. If they're new calcifications and they cannot be explained for any reason other than potentially an early cancer developing, then we would biopsy in this method. If we can see it otherwise under ultrasound, then that is the method in which we use. This is an irregular mass under ultrasound in the far upper screen, and the margins are irregular. What you see here is a needle that has been advancing through, taking small pieces of the tissue. We basically core it. You're taking a ball of tissue, and we're just punching holes through it. We do not remove the abnormality. So if it comes back anything as atypical or cancerous or precancerous, that would require surgical intervention. Now, because of the fact that all the masses do not look like that, we have benign masses, many of this method has been helpful in avoiding surgical biopsies. And immediately post-op, you might see the puncture site. That would be the small site. Might be swelling and may have a little bit of bleeding. And then later on, you'll have the bruising from the bleeding because we actually took tissue. But with the core needle biopsy, for a benign biopsy, is a lot better to have this type of result as opposed to having a scar and having to go to surgery and anesthesia to find out that the finding is benign. So we can do this within anywhere from half hour to 90 minutes to be able to get the diagnosis. Our pathology department is excellent and tries to get all of the breast imaging, all of our biopsies, throughput in what they call a stat fashion, and we try to get things read within 24 to 72 hours so that people don't wait long for their diagnosis. From the biopsy, we as the radiologists then actually get together with the pathologists. And that usually occurs on a Friday or weekly, and we review all of our biopsy results. And we actually determine if we think that the imaging findings and the pathology findings are in agreement. And that's what we call concordance. If we think there's a disagreement in what we find, then we call it discordant, and we notify the physician, usually the referring physician, and let them know that we think that additional procedures or imaging, maybe a repeat biopsy, or surgical intervention is needed. And the diagnosis must match the radiologic findings. Now, we do a multidisciplinary approach also. So once there is a diagnosis of breast cancer in Santa Monica as well, in the Westwood office, we actually have a group of multidiscipline, what we call different services. We have the radiation oncologist, medical oncologist, surgeon, radiologists and pathologists meet together, and we all devise a plan for what would be best for the woman in terms of how to manage her breast cancer. So this is how we've been doing this team approach from early on in the 90s, and it seems to be standard fare in most universities and other facilities. So this is something that is very important, and if there's any question about your management, these programs can be accessed through the breast centers in Santa Monica or at Westwood. So we want to have you ask some questions on Twitter using hashtag UCLAMDchat. I want to thank my fellow radiologists and also for letting me have these slides and developing this talk. And if there's some questions coming in, I'll be happy to answer. Okay. Let's see. Did you put it in a big font? Let's see what my glasses are. All right. Well, I have several questions here, and the first one is, are there any new imaging or new scans that are developing? Well, we have various scans that depends upon the modality. In nuclear medicine, there are some scans. PET scans can actually image some of the cancers as well. That looks adequately at the lymph nodes if there is a person with the cancer. In terms of the imaging, we're always hoping that there's another way to be able to image the breast without having compression. In terms of the technology, they are improving on all of it, and hopefully that what I'm more concerned, I'm actually finding breast cancer after the fact, after it's developed. Personally, I would like to not see it anymore. And where the research should be is how to detect the breast cancer before it gets to the point where it's imaged. Because sometimes the cancers are so small we cannot see it using imaging. And that is why I would rather have them work on the research in that realm. And so there are things on the fire, but it takes a while to get them to where they are for the public. There is one that is actually being utilized, I can tell you, that in mammography, just like how we use contrast injections in the MRI, some people are using the digital imaging. They actually inject a contrast and use it on mammography. And there are research programs and people doing the research work and evaluating that. So instead of having to use MRI to have that mass light up, some people are trying to use different techniques, and that has to determine the dosage of the amount of contrast that will optimize imaging the cancer. and other details that is what is called research. The next question, what is the difference in a screening mammogram and a diagnostic mammogram? And I think I answered that in the first question, but I will go back to that slide. Can you get me back to that slide? Thank you. Which was one of the very first. Screening, more before radiation safety, before that. Yes, and the one before that. The screening procedure, screening mammogram, again, asymptomatic, routine, coming in yearly, getting your mammogram, starting at age 40, no symptoms. And if we find something on the mammogram, or if you have a lump, then you would have a diagnostic mammogram. Or if you had a history of if your doctor, after you've had surgery, wants you to come in post-surgery to make sure that there's no residual disease, that again is a diagnostic examination. So again, screening is for asymptomatic women to detect small lesions not palpable and confined to the breast. And diagnostic is what we can use all of our tools of mammography, ultrasound, or MRI, depending upon the case-by-case basis. And those are women who are symptomatic or are post-surgical. How should I prepare for a mammogram? Well, I can tell you that the best way, is certainly for women who are premenopausal, that it's best to have the mammogram done maybe the week after you've had your menstrual cycle, so that the breast would not be so engorged or painful. And if you do have just painful breasts in general, that what I would recommend is that you take some ibuprofen or Tylenol before to reduce the effects of the compression. It's usually not painful, but it can be firm, and for some women it is painful. Some women actually get a little dizzy with the mammogram. Please let us know if you ever are a person who faints. We have you sit down and the mammogram is taken. But I would also recommend that you eat. There's no reason why you can't eat and have a regular examination. The next question is, should I have another breast imaging study in addition to mammogram? I think I kind of explained that. That's on a case-by-case basis. I think that depending upon what the density of the breast, whether you're a high-risk patient, we could have screening ultrasound or MRI. But basically for the general population and for those women who are in the fatty and primarily fatty breast category, that mammography is adequate for screening. But for those women, you should talk with your doctor in terms of what your risk factor is. Again, it's a relative risk. It's not an absolute risk of what happens, okay? And the next question is, when can I stop having mammograms? The thing about breast cancer is that it exponentially increases with age. So as time goes on, when you start in your fewer women who develop breast cancer in their 20s, as opposed to by the time you get into the 40s and 50s, that's when, and 60s is when you're getting into your, between 50 and 60 is when the peak many times of the breast cancer appears. However, we're finding women earlier in the age group of the 40s, and so that's why the recommendation for 40 screening came about. We image 90-year-olds. We don't stop. If you are a person who is active and you have breasts, you can have a mammogram. Of course, some of the women, I still recommend that women have their physical exams as they age, but some facilities actually stop imaging women as they approach their 80s, but I think that what is 80 now? So I think that we know that breast cancer increases because the breasts are a gland, and the risk of getting breast cancer increases with age. Okay, thank you very much.